I'm going to present Professor Raja Atreya. We welcome him in our meeting, in GETECCU meeting. He's a very young professor working at the Erlingen Hospital of Nuremberg in Germany. He has a quite wide curriculum. However, I should point out that since 2021, he's a professor for translational immunology in IBD. He has been head of the IBD department since 2013, which is 10 years from now. His PhD got a summa cum laude qualification. He was a rising star in 2015 by the United European Gastroenterology Federation, and he's currently associated editor of JCC and editorial advisory board for The Lancet Gastroenterology and Pathology. We will talk with Professor Atreya about one of the topics that we know the people that dealing with patients with IBD, it's for us a really big problem, and we know you love it because he has devoted his research to this topic, which is refractory IBD. First of all, thank you for joining us in our GETECCU meeting. And then, can you please provide a brief overview of what do you consider refractory IBD?
So first of all, thank you for the kind introduction, of course, also to the invitation to attend here the GETECCU meeting. And I'm very much impressed by the whole group and the organization. So I think if you now define refractory inflammatory bowel diseases, you would obviously say that you cannot reach a sufficient anti-inflammatory level with the medications that we have at the moment that we initiate. Luckily, we live in times where we have a lot of substances that have been approved for treatment, but nevertheless, we still have patients that do not sufficiently respond on a clinical or also endoscopic level. I think we have to take both factors or endpoints into account. So these are especially patients with ileal disease, I think in clinical practice that we see with perianal complications. I think we all know this is something where it's really hard to achieve a treatment response that is on a sufficient level. Patients that have failed anti-TNF therapy, I think this is also something where we know it's always harder a little bit for the subsequent therapy to really achieve a sufficient treatment control or also disease control. So I think these are the factors that really define refractory inflammatory bowel disease. And of course, we also have, I think, like new disease entities that we need to define, like for instance, of course, ileal Crohn's disease. If there's a concomitant primary sclerosing cholangitis, we also know this is something that's always hard to treat on a sufficient level, also to prevent the onset of colorectal cancer. So I think these are, let's say, the groups how I would define refractory inflammatory bowel diseases.
You were talking about the diagnosis of IBD, but do you consider that the window of opportunity that people are talking about at the beginning of the disease is important in terms of refractoriness of the disease?
Yes, I think for Crohn's disease, we have very good data that really show that initiated therapies are much more successful within the first 2 years of disease than later on. So, of course, this is associated, in my point of view, with the structural damage. If there's active disease, of course, there's also the onset of structural damage, also onset of fibrosis. And we all know, for instance, in strictures, there's like a certain part of inflammation, but probably even a bigger part of fibrosis. And we don't have antifibrotic medications at the moment at our hand. So, of course, anti-inflammatory therapies that we then initiate do not achieve sufficient treatment control. So I think this is something that we have to take into account. And in ulcerative colitis, there are data that show that later treatment initiation is not associated with a worse outcome. But I think we do not look, let's say, specifically enough, because if we take patients that have a development of extension of disease going from proctitis to subtotal or pancolitis or subtotal colitis to pancolitis, we do see that there's a heightened rate of colectomies in these patients. I think these are the patients that we have to monitor and intensively treat as early as possible to prevent perhaps even disease extension and higher probability of refractoriness.
So in your center, how do you deal with a patient that you consider it will has this qualification of being refractory, to have refractory disease, like talking about Crohn's disease and ulcerative colitis? How do you deal with it?
I think first of all, we try to utilize the maximum strength of the available therapies that we have. So I think we all know that from clinical practice, we intensify the dosing or reduce the frequency to perhaps get a better treatment response with the available drugs that we have. We also, of course, have the combination therapy with anti-TNF therapies, mostly infliximab, combining it with thiopurines or methotrexate. to prevent anti-drug antibody formation and perhaps enhance the treatment response in these patients. On the other hand, we always, if all this does not lead to a successful treatment in the patient, we of course also always have to think about the surgical option before perhaps even going through all the medications that we have that at the moment. Perhaps sometimes we miss the best spot for the patient to go to surgery instead of initiating the 5th, 6th and 7th line therapy, which we can theoretically do at the moment. So I think this is always important. But of course, there are some patients that are not amenable to surgery if there's an extensive ileocolitis. So there we have to see if perhaps we can initiate an off-label therapy, if the patient can participate in a clinical study with newer compounds. So I think these are the new ways to go, perhaps to offer the treatment, the patient's treatment that go beyond the approved therapies.
Do you think there's a role for personalized medicine dealing with this kind of patients?
I think not yet. I think we have to do better in defining who these patients are on a molecular level. I think we have to really perhaps define the subgroup of refractory inflammatory bowel diseases. We only have clinical parameters at the moment. We don't have any molecular parameters, and I think only we can identify these markers. Perhaps then we can also identify the best treatment options for these therapies, and I think these options go beyond what we have at the moment approved in our daily clinical practice.
So you're saying that we don't have these biomarkers, but maybe we do have any genetic marker that can help us dealing with these patients or not?
I think not at the moment. We used to think with NOD2, of course, that is associated with complicated disease, but probably it's more associated with ileal disease. And ileal disease has more complication with strictures, for instance. So I think at the moment we do not have any genetic markers. I think there's one marker for heightened probability for the formation of anti-drug antibodies. Okay, but even nevertheless, combination therapy is more efficiently even if you don't have the genetic predisposition for anti-drug antibody formation. So I think at the moment I cannot see really any biomarker besides markers for inflammation, like fecal calprotectin, CRP, but endoscopy, but that we already have and know. So at the moment there's no molecular marker that helps me in clinical practice.
Okay, yeah, we're talking about markers of inflammations, no? So do you have any idea of emerging therapies that we can think about, maybe we can use? Are there any breakthroughs in the horizon or something that you can tell us about this?
I think combination therapy is perhaps the way to go. We all know there's a certain treatment success with the monotherapies, but I think the combination of biological therapies, we are doing this if a patient has two chronic immune-mediated diseases. Let's say there's an inflammation in the joints, inflammation in the intestine, then sometimes we combine therapies that are efficiently in both disease entities. But perhaps even for inflammatory bowel diseases, and we have seen the results of the VEGA trial, when anti-IL-23 antibody guselkumab was combined with an anti-TNF antibody golimumab, and we could see better induction results that were impressively better than the monotherapies. And there's an ongoing study now for induction and maintenance therapy, and perhaps this might be also on a molecular level very good combination partners, because I think IL-23 is one of the drivers of resistance to anti-TNF therapy, and that by suppressing IL-23 while ongoing anti-TNF therapy is there might be very a beneficial way.
And any info about JAK inhibitors?
Yeah, I think JAK inhibitors have shown, I think that's really a huge advancement also in our therapeutic options, that they're efficient irrespective of the previous therapies. So I think probably they're one of the best treatment options for multiple failures, of course also for naive patients. But I think something like suppressing really then on a broad, let's say on a broad array of inflammatory pathways like JAK inhibitors do, might be the way to overcome resistance to the monotherapies.
Okay, so the last two questions will be, do you think that multidisciplinary teams are important dealing with patients that have really severe disease, or maybe they have risk factors of considering them at risk of having a refractory IBD?
Yes, absolutely. I think it's important to include like pediatricians. We all know where transition is really that important also for beneficial therapy for the adult or teenage patients. A surgical partner, a radiological partner. I think we need these multidisciplinary meetings. Also outside our specialties, for instance, if there's a dermatological or rheumatologic disease, I think getting together is the best way for these patients. I think these patients should really also be treated in centers that have experience also with off-label therapies, with clinical studies. So I think this is the best setting that we can offer our patients.
And any key message that you want to leave at the last words they have here in our podcast?
I think we have new technological possibilities also in science, like all the multi-omic procedures that we can perform. Hopefully they will help us to stratify the subgroups that we have in both disease entities, was what we nowadays call Crohn's disease and ulcerative colitis. And I really hope, let's say in 10 years, that we can identify these subgroups. I think if we identify these subgroups, probably based on a molecular level, we'll also find the best treatment options for this subgroup and perhaps really prevent refractory inflammatory bowel diseases.
Thank you very much. The topic is really very interesting. Thank you for coming again. Hope to see you soon here, and thank you again.
Thank you very much.